Hi, uh, my name's Philip Brunner, and this is part of the clinical praxis class. And I will be asking questions about suicidality. Can you introduce yourself real fast?
Hi, I am Alissa Collins, and I'll be answering the first set of questions.
All right, so I'm going to ask you about 10 questions, and here comes the first one. You ready?
Yes.
Okay. So, as a practitioner, or as practitioners, when sitting with a client's suicidal pain, what's the most helpful lens or mindset you try to hold on to? And why does the particular approach, like, maybe a dialectical or narrative one, feel like it best handles the gut level uncertainty we always feel?
Um, I would say that I connect with the narrative approach here. Um, the most important mindset would probably be curiosity without some fear. Just trying to make sure that I stay grounded and trauma informed, and using trauma informed care and relational lens. Uh, I work with a lot of younger youth, so I think I would try to see suicidality as not something that I can fix, but just a story that I can understand, especially because a lot of our youth that I do work with, like my oldest client is 9 years old. It's hard to kind of understand what they're saying. So it's trying to use what they're feeling and they're saying by like the way that they're like throwing their toys to be able to kind of understand what they're um, going through with their pain rather than trying to eliminate it. So just
Mhm.
staying more attuned and less reactive. And I think that's why I would connect with that narrative approach more.
Okay, that sounds good. All right, number two. You had to distill our work down to one guiding principle. What's the biggest shift in mindset we need to make? Like beyond just the immediate safety contract to truly help the client find a way forward.
Honestly, it's shifting away from moving. It would be moving away from like, how do I keep this person feel safe right now, and how can I continue to make this person feel safe enough to live? Uh, and somewhere in here I read about a safety contract, but that's just something that's a momentary intervention. I- I'd want to work with making sure to help build the clients rebuild their connection, their purpose, and their sense of belonging into the world. So for me, and some of the work that I've done, I've worked with youth who have lived experience or some with foster care. Um,
Mhm.
so a lot of their suicidality, it's rooted in disconnection. So it's just trying to find. Um, there was a guiding principle that I was talking about. It would be safety. So helping them experience like steady, non-judgmental relationships, and then let them know that they're not alone in the world.
Okay, sounds good. Number three. When a client is in a high risk, high urgency space, how do you handle the internal pressure? Like, what are those two or three non negotiable steps you take to slow down your own anxiety and make sure you're truly getting their story, like Friedenthal encourages?
We just did this last week. We had a young lady who was experiencing all of these types of symptoms of being on the verge of committing suicide, and I had to talk to her. And my first step was to just breathe, breathing and making sure I wasn't sweating, and I had to literally consciously slow my body down.
Mhm.
Um, and I couldn't panic. I think that was the biggest thing was like I knew I was sitting with all of this information and I just needed to remind myself that um I needed to not panic and to just keep breathing and then keep asking. There's this other piece called like stay curious, so just trying to stay curious about everything, keep asking questions. I, it was just keeping a conversation going. um Friedenthal talks about inviting the client to walk you through what it feels like when they feel hopeless. So it's just
Yeah.
trying to get their story out and just hearing it piece by piece. That also helps slow down as well. Then this way you can get more of accurate information, and I don't feel like I'm overwhelmed in the moment either.
Yeah. I like that. It's really hard to not be panicky or anxious when someone in front of you is talking about committing suicide.
Especially because these are children. These are,
Exactly. Yes.
I work with children in foster care, and they've had a really rough life. By the time they've gotten to me in treatment foster care, they've been diagnosed with different things, and they haven't had a cakewalk of a life. So if
Yeah.
my children are at this point and they are talking about these things, it does get a little bit it's scary, just
Yeah.
because you don't really. I'm not used to having this because my caseload has been from like babies to about 5 years old. So when you
Yeah.
start getting those older children, it's just a whole new like
Yeah.
ballgame for me.
It's a lot different, that's for sure.
Oh yeah.
All right. Number four, Regier et al. Talk about how easily our own biases creep in. So, what's the one bias, like, defensive decision making, or you worry about most in your own practice when the risk feels high? And what's your personal check in phrase or action to mitigate it?
Mhm. Um, uh, Honestly, I think I often have to realign my values a lot when I'm working with foster parents, youth, because my life, you can't stop to think about your license being on the line a lot of the time. So just make sure you're making the right decisions. So you try not to overreact, and try to protect yourself over what's best for the client. So you have to stop and ask yourself, am I acting out of like fear or care? Do
Yeah.
I what's going to be the best decision for this youth? Do I, you know, yeah, I think that's the biggest thing. Is this out of fear or out of from care? And this again helps me realign my values, because um, when I get to my supervision piece, I have to be able to talk about it and reflect on it, because um, I do find that when you read the piece in one of these articles, that decision making, the way that you decision make drops when you're stressed or you're full of
Yeah.
fear. And and I'm telling you, when it's the moment that you move on from these situations and like it escalates, like the young lady did have to go to the hospital. So it's
Mhm.
you just want to make sure that you did everything that you were supposed to do right. And I think uh, at the end of the day, it was I did too much, and I would rather do too much than not enough, because I was scared of like losing my license or something.
Yeah. Yeah, I'm definitely aligned with you on the whole keeping values like on the forefront of your mind thing.
Oh yeah.
Because when you are anxious, it seems like there's a lot of like cognitive interference happening there, and it's like hard to access certain parts of the brain that you normally can, and you're like, and you're like, okay, I'm gonna have my ethics, I have my morals, I have protocols, I have guidelines. Just stick to that.
Oh yeah.
All right, next question. All right, Friedenthal warns about how involuntary hospitalization can sever the relationship and cause trauma. Right? How do you personally wrestle with that dilemma? Like the immediate need for safety versus the risk of rupture, and what criteria have to be absolutely met before you involve an involuntary step?
Well, in this particular area, and I'm going to keep referring back to this 9-year old, because I just went through this with her, and I would say this would be the hardest part of my work. It's it, it's traumatizing to somebody. You're really rupturing the trust, and especially since this young lady probably already feels super powerless.
Hmm.
Um, when they had these thoughts and they said these things, you want to make sure that there was clear intent. There was, in this moment, if I leave, is anything going to happen? So I just want to make sure that I'm super transparent. I tell her, I don't want to make the decisions about you. I want to make them with you. And that's the part that I want to let them know is if we reach that point, which we did, I have to explain every step, letting them know that their safety is my top priority and especially their dignity as well. So just making sure I'm transparent all the way through from the very beginning of, you made these decisions, you said this is why we're going here. And that also helped that, young lady
Yeah.
understand. But yeah, again, it's the hardest part of the work, I would say, is just knowing that, when I go to visit her on Monday, that, that trust is probably not going to be there because she had to spend her weekend in the hospital.
Yeah. Yeah. I feel like we got to do uh, the best thing that we possibly can, even though we're aware that it might hurt our rapport with them. But a lot of times afterwards, like we can reconcile with them. You know what I mean? And it's recoverable too, right? Like, so they might be upset in the moment, but then maybe afterwards, like, yeah, I agree that was the best thing to do, and then you can move forward with them.
Yeah,
Most of the
absolutely.
time, that happens. All right, next question. Uh, Friedenthal champions suicidal storytelling. When does that invitation to tell me the story happen in your clinical encounter? Like, how do you find that just truly listening to the narrative naturally gives you the risk data you need while also building hope?
I would say just introducing that early. Just can you tell me about a time that can you tell me about a time when those thoughts felt the strongest? And when you're given like a young child a PHQ-9, it's just trying to ask them follow-on questions. Like what was happening around that time when you first felt that it was like too much. Just letting them tell that story and making sure that you're not interrogating them. So like I would shift from asking the rest of those questions to try to get to just feel like I'm more understanding rather than interrogating them because I feel like they can really pick up on when you're asking questions to ask them and versus trying to
Yeah.
understand. So
Yes, exactly. I think so.
yeah. And for me, these little kids are smart, so they know. Um
Yeah.
yeah, and then I think that if I shift to trying to understand rather than interrogating this, the stories will just kind of come out naturally. And then you could kind of just hear the reason, they might be able to reveal any of their attempts for coping or any strengths that they might have, and then ultimately
Yeah.
just trying to get to those things and those reasons why they're still here. So
Yeah.
yeah.
That's good. Yeah. All right. Next question. Whiteside highlights that a lot of like crucial information, especially around the history of suicidal behavior, gets lost in the handoff. What's one practical thing we can do beyond a basic discharge summary to ensure genuine continuity of care for this client, maybe when communicating with a new provider or primary care?
Yeah, there have been so many times where the youth just fall through the cracks during these transitions, and especially when they're leaving treatment foster care and they're going to like a higher level care, like a diagnostic center or something.
Hmm.
And I, you feel bad because you send your discharge summary over and then you get them to sign off on it and then you go and um, uh, one great thing for me was I got to take a past youth to the diagnostic center,
Hmm.
and that was like a really neat handoff because I physically took her there and I was able to have like a couple of weeks of meeting with that person when she was placed into that diagnostic center. So it was just a really small thing.
Hmm.
But also just if it's not that big, you could just have calls with the providers to just kind of talk about the little things that they might have and the little things that they might have in going on just to be able to maintain that human bridge uh, and just make that whoever you are helping feel like they weren't just handed off to somebody because at the end of the day you might be the person that they trust or that they have built that relationship with. So allowing that to just phase out without it being completely severed entirely.
Yeah. 'Cause a lot of times our notes don't transfer over or translate over very well to other agencies. So yeah, that's awesome.
No, and if we're being completely transparent here, when we get youth placed into our care,
Mhm.
and DSS drops them off at doors, we assign a foster parent and they just drop them off. They're dropping the children off sometimes with just the clothes that are on their backs, and that's it. And it's not, and then you get all
Yeah.
your information from foster parents and stuff. So it's these kids, and then this is just a real story where the three young children were having, terrible experience, and they were just dropped off with a complete stranger rather than, the person they had just spent the whole day with. So
Yeah.
it's, you'd want to make sure that they were handed off in a nice way where you you talk you I don't know, you would talk to them, make sure that they felt safe with the person that they were being dropped off to, because they were already in a high level of stress situation with the situation they were just living in, and then you put them in a stranger's home. So it's, yeah,
Yeah.
it's trying to just be present and not just continue to traumatize.
I know, right? Yeah, it's very challenging for sure. All right. Next question. All right. For clients with a chronic pattern of suicidality, the work shifts from crisis management to building a life worth living. What's one tangible tool you enjoy using, a hope kit or a DBD skill, etc., to move the conversation from why not die to what's worth living for? And how do you introduce that in a way that feels empowering?
uh yeah. Yeah, so I think in this situation, I could help them um, create create like a box of something that has like tangible things in them for them to be able to want to live. So, with a lot of the children I work with, having a picture of their parents, having drawings from their siblings, those types of things could go in a box. If mom would write them a letter, or and then in this terms of these children, when it gets dark outside, or when it gets dark in your world, what do you want nearby you to be able to remind you that who you are, why the world still feels like it's worth living in. So yeah, just having a little box of those things to be able to have that, and then yeah, I think, yeah, the I would have like a little small box kit.
That's good. I think sometimes the anxiety of practitioners going just from "please don't die" to "why should you live" is probably a challenging transition, but it makes it, uh, I think, more empowering for the person to even think about, like, why should I live versus why should I not die? Because I think that's how most people approach people in suicidal situations, is like they only hear that why they shouldn't die, not why they should live. So I think it's just empowering to even use the language, and the motivation to live versus why you shouldn't die, right? So I think that's a big shift there.
Yeah, and just trying to build on why not die, and shifting that towards what still matters in your world. Like, what it's such a small phrase, but
Yeah.
you can
Yes.
connect them to something, and making sure, like, hey, your life is worth living.
Yeah. I think it's significant. Our language with clients really matters too, and this is just
Oh
one
yeah.
way to represent that. All right. Question 9. Almost there. When working across diverse backgrounds, how do you make sure your framework isn't culturally biased? Can you share an example of a community specific protective factor? Something outside the clinical room, like an elder or ceremony that you would prioritize and weave into a safety plan?
Yeah, it starts with just, I would say, no, I'm not an expert on anybody else's experience, and I would say that, Yeah, it's tough because I come from a native background, and it's just trying to figure out what's encouraging to them, seeing if they have like a church mentor. I did have a client once who belonged to the she was from Bangladesh, so it's uh trying to get her involved in those different types of holidays that they celebrate, Ramadan, and just trying to get her connected to those things, because she felt safe when she would go to prayers, and she felt safe when she could be secluded in like a room where she could safely pray, because she did feel like she was an outsider, especially with the type of like clothing that she had to wear. So just you have to encourage her to make sure she found a place where she felt affirmed, because um, these what is it called, the protective factors, they go belong clinical settings, they're it's their identity and their belonging, and just making sure that she was also placed somewhere where the person also cared about all those things for her. So making sure she had halal food, and those things just really make a big difference as well. So
Yeah.
it's
Yeah.
um, making sure that I was versed on those things of, I shouldn't come at these times to see you because you should be praying, and stuff. So it's just yeah, it's so the protective factor. Yeah, connecting them to something that makes them feel affirmed.
Yeah. A lot of times, just asking the client too, right? Like they have a lot of insight into what makes them feel safe as well too. Especially if you meet someone for the first time that has a different cultural background than you do, and you just met them, and they're already having this crisis in front of you. Like just asking them sometimes will give you enough to build into the safety plan. So that helps too, and that's pretty simple.
Yeah, and as soon as I meet a client too, we give this like interview with them, and one of the questions on there that talks about, like, if you're not feeling safe, who do you feel comfortable telling if you weren't feeling safe? And it's a question that you get a lot of side eyes for, because it's like, well, I've never really been asked that. Um,
Yeah,
so it's such a unique question that I watch out for reactions, because you can tell that a lot of people just haven't been asked, who do I talk to if I don't feel safe? They've just never heard that stuff before.
yeah, yeah. But when they do answer it, I'm sure it comes in handy, right? So
Oh yeah, absolutely. Or you just be surprised at their answer too.
yeah, yeah. All right, last question. All right, Whiteside emphasizes the power of lived experience, nothing about us without us. How do you actively step out of the expert role and leverage the client's own hard earned wisdom about their survival? Like, what's one question you ask to affirm them as the expert on their own pain and recovery?
A question that you could ask would be, what's helped you get through the hardest nights before? Um, or just to try to get an understanding, to put the question back on them. What what do you wish that professionals understood about your pain? Because this helps. You'd want to remind them that, I think this could also remind them that they've already survived a lot of the difficult times in their lives. So it's just, who did you tell that you were able to get through all this stuff, and then what do you wish that we could understand, and what could we gather from your pain to help get you through these? Because I've realized that my role is here to be able to help make sure that, yeah, my roles here is to help, and make sure that I'm helping the resilience that they've already created. So whether or not they've gone through, you know, all the ups and downs, and it's just validating all that, and then so I'm not replacing it with anything. I'm just trying to validate everything that they've gone through, and then Yeah, I think that because lived experience is so valuable. They are the only ones who've known what they have been living through, whether it's
Yeah.
homelessness or living with parents who have had some sort of something. So it's just, how you're still standing here. So what has helped you get through those hardest nights before, and how can, and again, what can me, myself as a professional, and those who you work with, what do you wish we knew about your pain?
Yeah. I find that from the beginning through rapport building, acting like they're the expert of their life is important. But every once in a while, like that person comes out in me, where like I'm the expert and you're not. Please do the right thing because I want to see you live your life better. So there are times where it's just like, you gotta tamp it down a little bit. They are their own expert, even if it's even if they're saying stuff that you don't think will be advantageous for them. But they know more about themselves than we do. We're just catalysts for them.
Absolutely. So, when we talk about all of these things, I'll shift into some of my questions and, my piece about everything. And um, I I can't help but think about how uh, I'm very thankful for a lot of these screening tools that we have because it really helps like break a lot of the conversation up when you're talking with people. And
Hmm.
I don't know if you're familiar with like a PHQ-9 or anything, but it's like something that helps identify risk.
Hmm.
And even when I've gone to doctors' offices, they give them to me too, and I'm just like, wait, are you PHQ-9 me right now?
I
uh,
know that questionnaire. I know that assessment.
I just had a baby too, so I remember just getting that, going to a doctor's office and they were giving me one, and I was like, wait, are you giving me these? I give these. But it's um I've learned that what happens next after you give a PHQ-9, it really depends on our judgment and the stress, the experience, and then even like that person's comfort that you're going through this with. It shapes how we assess the situation and how we respond. And when I've gone through a lot of these things, I've seen firsthand, when a youth when they respond in a negative way to these, it's the system that's in place. It pressures us to ask super quickly, or it pressures us to act really quickly, and
Hmm.
it's hard to like stop, pause, reflect, and try to like figure out the whole bigger picture of everything to just kind of make sure that you're having like you're using all the stuff like that before you make it get out of control. And I think that oftentimes we jump straight to worst case scenario here, and I only say this because in my own practice I've done this where I've you're just if I'm like emotionally fatigued or if I'm nervous about the situation, I've jumped to a conclusion and I've immediately jumped to a safety plan, and um just turns out that the children didn't really understand how to answer the questions. So it's really taking the time to make sure that I'm making sure that I'm being thorough with those. And um yeah, so I'll ask you a few questions, but a couple of the yeah, I do have a few questions to ask you. If you
Okay, I'm available.
yes, how I'm gonna jump right into it. How do you balance structured suicide risk tools with your professional intuition or your gut feeling?
It's a good question because especially where I come from in a substance use background, we have to use these tools pretty frequently, like the Columbia Suicide Severity Rating Scale, and then, of course, the PHQ-9. And I think the last question is about suicidal assessment. And then they provide like necessary standardization of risk assessments, which, it's important for documentation, meeting your agency protocols and all that. But sometimes these tools are like sort of inherently limited by clients' willingness or capacity to be fully honest because they hear them so often. They sort of just like know what's coming and they just answer it and they know like how to answer it. And so then when you sort of sense that in a client because you do this all the time with them, I rely on my professional intuition or like gut feeling as a signal to shift from a structured interview to like a more of a person-centered, genuine connection. This is where I like really start to get curious about what they're going through and what's happening with them. I think that's a concept strongly advocated by Friedenthal. So, like when a client is overly facile with the assessment, my intuition prompts me to integrate inquiries about like lethality, intent, planning, stuff like that, and a more natural conversational flow. So, you get rid of the more formal reading of the sheet, like, have you done this? Have you thought about this? How often have you done that? Like once they hear that language and that tone and cadence, they just automatically just sort of disregard it. It's important, like I know this is just part of what you got to do. Okay, let's move on to the good stuff. And then you're like, but I really want to know, like, how are you doing? Are you thinking about suicide? Like, what's your life like? Are you sleeping okay? What's your, appetite like? Stuff like that. So you just have to like just then integrate those questions or the idea of the question into a conversation to like really get them to open up to you. And I think this aligns with the idea that relational component is the most potent intervention. My clinical competence sort of requires me to use the tools as a starting point, but my effectiveness relies on using a relational approach to elicit more truthful, nuanced information, recognizing that assessment, it's an ongoing process, not a one-time checklist. So, and it's very personal. So I try to make it personal.
Yeah, that's great. And it's great that, you use your structured tools in the beginning, but then you switch to, you know, uh, I know you're also a human here, so
Yeah, yeah,
let me try to not throw papers in your face. And it's also like that white coat syndrome too, right? Where it's like, yeah, there
yeah,
sometimes people don't respond to people wearing white coats and they don't respond to that and they respond to somebody who's
exactly.
who's who's kind of like looks like them and is,
Yeah.
so it's yeah, I see where you're coming from there.
Yeah, and a lot of them have been through institutions for many years, and they can recognize these questionnaires quite easily, and they probably know them a lot better than I do as well too. So, they're pretty familiar with how to answer them, and you know, they determine whether or not they want to answer them truthfully. But if there are some red flags that came up in conversations either before or after the questionnaire, then I will shift gears to find out more about what's going on with them.
Awesome, wonderful. A question two, if you're okay with moving on. In what ways have you noticed your own comfort or discomfort with uncertainty impacting your decision making?
Good question. Well, my comfort with uncertainty, I think, is routinely challenged when making critical safety decisions. As a practitioner, like the required stance is to hold complexity, uncertainty, and hope simultaneously. While I embrace uncertainty and the creative aspects of therapy, I think the moral responsibility inherent in suicide risk assessment creates a lot of discomfort for me. So my response to the discomfort is to employ emotional regulation the best I can, and I practice mindfulness. So I use that to prevent like a reactive decision based on my anxiety. Uh, Yet, as I think Rigier et al. Describes, systemic pressures often influence clinical judgments. Therefore, like I kind of work to remain within established protocols. They're my guidelines, like not just because they're required, but because they provide like an ethical and evidence-based anchor when my personal discomfort is highest. You know how you talked about like your anxiety makes it where you can't like think clearly.
Mhm.
So if you like sort of reinforce ethics or protocols enough, they're like there, or even have them like written down on a sheet of paper somewhere, like next to your desk. So just follow those things when like your mind is a little bit of a mess. So the discomfort itself, when managed effectively, it can be a helpful signal to slow down, and consult. And I always like to consult before I make any real decision, especially with like involuntary hospitalization, rather than just like rush to a decision. That answer your question?
Yeah, it certainly did. It's it's just trying to tie in the it's also just trying to take a step back because I work with such a different population, and like I said earlier, we work in two totally different types of work. So it's just trying to catch a lot of the things that you're saying because it's interesting because I'm also learning about like what you're doing in your work as well.
Yeah. Suicidality is very common with people who have comorbidity, so it's something I have to deal with a lot, and I still feel very anxious around it, because I always feel uh, like an imposter with competence in relationship to suicidality. Never want to make the wrong decision because you feel like that can affect the other person very distinctly and in not a good way. Like, so you think your mistake can lead to them committing suicide, and you have to sort of work with that a lot. Like, you know what I mean? You don't want to say the wrong thing, do the wrong thing because you don't want it to be a reason, right, for committing suicide. So you're managing that the best you possibly can.
Yeah, and I appreciate that you have that level to be able to think about those things. And off topic here, my mom just went through like a program where she lived as a resident for substance
Hmm.
abuse. So it's
Hmm.
hearing it's so wild to me that something so close to home. I never even thought about the word of suicidality and thought about like were these thoughts in my mom's head. I was just so focused on like that, like substance abuse part that I didn't even think about
Right, right.
like that part, or not even thinking about the clinicians that are there helping her. Do they think this way? Do they have that same level of care that you just talked about? Making sure that you're asking all the right questions, saying all the things that you need to say. And it is those thoughts just popped in my head about like I never thought about the social workers in that situation when I probably should
Well, that's the thing, like the shoulda, coulda, woulda thing, right? Like, and
have.
then
Yeah,
like then you have self care around like the shame and guilt of maybe not asking the right questions or thinking the right thing. So it's a lot to manage. It's a lot. There's a lot there, right? So that's why
yeah. And then you
this
wonder why,
topic
like,
is
then you
important,
wonder
I
why,
think.
like, this is why I'm asking a lot of questions. Next question. Do you have any, what biases or assumptions might influence how you interpret the suicidal statements or behaviors across the different populations? So again,
Outside of, go ahead.
yeah. So outside of what biases or assumptions might influence you? What biases or assumptions might influence how you interpret suicidal statements or behaviors across different populations?
When I first thought that came to mind was like, "Oh, that's never happened to me." And then I'm like, "Oh yeah, yeah, it has." Okay, so I have an internal bias for this, uh, which I have to actively check. Is the assumption that a client with a history of personality disorders, specific personality disorders, uh, they are sometimes they utilize suicidal attempts for leverage or manipulation. So I have to disregard that, even if they have been diagnosed with that personality disorder or if they present in that way, because I think that's sort of like a dangerous oversimplification. And I try to work through that by treating all disclosures of suicidality with like the same level of immediacy and like comprehensive assessment, regardless of whatever they were diagnosed with or whatever their behaviors were in the past. So I try to recognize that our assumptions about authentic suffering like versus attention seeking are biases that can lead to serious or even fatal errors. So the literature, I think, emphasizes that all suicidal ideation is a communication of like distress. It must be met with non-judgment validation. So it's something I pride myself on, is being non-judgmental. So at times, if there's a particular person there who has that personality disorder, I have to work through it. And, I have to do a thorough risk assessment, despite whatever my feelings are about that, just in case. So the goal is to try to separate. the assessment of risk for my own subjective reaction to the client's presentation, or I can fail them as a practitioner. Yeah, I don't want that. But it's work. It's work sometimes.
Yeah, it's you have to separate that both of those, and do you have to like work with like another clinician as well to help with that type of thing, or do you have to handle all of it?
I would like to say that I got to work with other people on that, but for the most part on my own. I had a good supervisor who did work with me on those types of things well, but I don't have one currently. So
Oh, gotcha. Oh man.
that's some of the topic of my capstone now. Is like this gap, right, between theory and practice, and competence and supervision and all that thing, and training. Like, how do we know as practitioners that we have fidelity in our interventions, that we're doing well without appropriate supervision? Like, we have to find our own ways to assess ourselves if we don't have proper supervision. So that's what I'm working on now.
Yeah, that's totally valid. So I could see exactly why you would be having that as your topic for your capstone. Um, my next question is, how can clinicians adapt evidence-based practices to fit diverse cultural, social, or environmental contexts?
I think adapting evidence-based practices requires like a certain commitment to cultural humility, which sort of involves an ongoing self-reflection and recognizing the power dynamics inherent in a therapeutic relationship. As I've learned, cultural humility paired with intersectionality lens allows me to see how layered identities shape a client's experience of crisis and their response to standard evidence-based practices, because they don't all respond the same exact way. So, like, I don't know, for example, a standard safety plan may be useless if it doesn't account for like socioeconomic barriers to accessing support resources. I think effective adaptation means like decentering the standard protocol and collaboratively integrating clients' cultural definitions of support, community, and well-being into the intervention. So this person-centered approach sort of makes sure the intervention is like culturally responsive rather than culturally blind. I've made, I think, those mistakes the hard way over time, you know, making assumptions about what people have access to, and their cultural response to particular things, or what's important to them. So I try not to make too many assumptions, you know.
Yeah, at least you know that you can try not to jump to the assumptions and um, yeah, that you can fix that and you have the ability to work around all of those things because it's hard when you're working with different backgrounds and uh, or just I had a child with a language barrier and like it's very very specific dialect from Guam and I'm like, oh sure she can understand me, sure I could speak into this cell phone
Yeah,
and we could interpret it, and it's like just assuming and thinking like maybe she does know more English than I'm giving her credit for, but it's
yeah, yeah. And a lot of our safety plans have like sort of a built-in like framework, and a lot of it is like, especially with people who don't have any like even peer supports, like you can't just assume that they are going to be able to access people in their lives in the same way that others are, just because it's sort of like embedded into like maybe a standard safety plan, right? Like, don't forget, reach out to your friends and hang out with them. Like, they're like, I don't have any friends. Like, okay, so now you got to work on something different. Like, making the assumption that they have people in their lives is a problem, or that they can even access their friends, even if they had them, right?
yeah,
Sometimes they don't have phones or computers or money to catch a bus or whatever. So, we have to just sort of keep these things in mind when we're making safety plans that can actually execute them, you know?
yeah, because it's so easy to just say, hey, you can catch this bus and this is going to get you to school or this is going to get you to where you need to be, but really do you have like the ability to do everything without like you said, a phone or yeah,
Yeah,
so I get
yeah.
that. So question 5 really has my gears turning because I'm now that and I should have known because I've read we've talked about your capstone before, but now I'm really curious because this question talks about supervision. So what role does reflective supervision play in strengthening suicide risk assessment and response, would you say?
I think it's pretty significant. I mean, because it provides a space to process like the emotional and cognitive challenges inherent in suicide risk. It's not just about like sort of reviewing documentation, which a lot of supervisors like just sort of focus on, but it's more about examining like our competence and emotional capacity. I think that's kind of important, you know. The supervision process supports practitioner developments by like challenging, I don't know, blind spots and risk judgment that might stem from, you know, our bias or our counter transference. You know, building confidence in decision making is very important. I think, especially in this field when you're, like I said, you're dealing with suicidality quite often, which you know addresses our anxiety and fears about making a mistake and facilitating aftercare for the provider, mitigating the risk of vicarious trauma as well, and emotional fatigue, which you know burnout is quite common. You know, these are factors that I think Regier et al. Highlight as impacting judgment. So, you know, once you get to those places in which you don't have the appropriate supervision and you might be burnt out or you're fatigued or you have this, vicarious trauma, like, you know, it's going to impact the way you start treating clients moving forward. So, uh, reflective supervision, in my opinion, is a necessary safeguard for maintaining competence and ethical integrity required for effective suicide prevention work.
Yeah, and this rolls into my next question then, because if like you said, you don't have like a supervisor right now, and you don't really have somebody to be able to bounce these ideas off, then for you and some of your colleagues, then how can you support your colleagues who might experience emotional fatigue or vicarious trauma from working with people with suicidal when you're working with suicidal clients?
Yeah. I only laugh because it's something I've been sort of dealing with for quite some time, with not being the like official uh, therapist among therapists, right? So
Yeah.
my approach has sort of evolved to prioritize systemic support over personalizing the peer support role. So while encouragement and empathy are, you know, they're necessary for maintaining collegial relationships, I think true support for emotional fatigue and vicarious trauma must be channeled through their professional and organizational structures. You know, so I offer empathy toward them, but then I guide them toward resources that are available to them, like either a supervisor or the organizational employee assistance program, and especially their own mental health providers if they have them. So the boundary reinforcement is based on the understanding that addressing vicarious trauma is a clinical need, and supporting a colleague in that role can contribute to my own fatigue and burnout. And it generally can, because at times I could have multiple colleagues in my office for like all the free time that I have throughout the day in between clients. My colleagues can see that I have a space and they'll come in there and take up the space right away. So I don't have space for myself. So I had to start like establishing stronger, healthier boundaries for myself instead of trying to save everyone, including my colleagues. So, you know, the organization has a primary responsibility to manage that. Uh, like the workload and documentation demands, you know, that lead to provider burnout. Like it's sort of their job too, you know, like take care of their people. Sometimes they don't, but it's not my job either, and I can't take on that full responsibility.
No, you're there to, support your clients and make sure that you're doing your job. And sounds like there are a lot of other challenges that are in the way as well.
For sure.
Yeah. So last question, because I am curious about Sorry if you hear my child in the background. It's his bath time. Um, last question would be, um, the Roger talks about organizational culture, so your workload, administrative demands that often shaped your clinical judgment. How do the systemic pressures, such as like documentation requirements, your policy mandates or your time constraints, impact your ability to engage in reflective, person-centered suicide assessments?
Hmm. Yeah, it sort of gets to the core of my capstone again, as Roger argues, organizational culture, workload, administrative demands, all that often take priority over clinicians', judgment, competence, and well-being, which we just talked about. The impact's big. I mean, like time constraints force a reliance on the structured tools as a checkbox exercise rather than a reflective dialogic process, and documentation requirements sort of shift the focus from the client's lived experience to satisfying a paper trail. The statement, don't worry about it as long as you document it, ever quite often like illustrates how risk management supersedes client care and a safety driven culture. So, these pressures create a feeling of incompetence and ethical strain when our professional judgment is ignored in favor of policy. That's a problem. As a practitioner, the commitment to growth means continuing to prioritize, person-centered assessment and advocating for a culture that supports clinical expertise despite, systemic impediments, challenges, and barriers, which I've been doing for quite some time.
Oh man, yeah. This is That's a great response. I appreciate you, taking the time to really, you know, talk about that one. So then I'm just gonna go ahead and ask you the last one because I'm really curious about this piece, just because Dr. Whiteside talks about they reframe suicidality as a distinct behavioral disorder, while the Friedenthal talks about how it's the power of genuine connection and hope. And um, I'm curious, what does it look like for you clinician to hold hope for clients struggling with suicidality while maintaining a realistic awareness of risk and safety, especially because I remember you're talking about um, comorbidities and things like that. So I just would be curious, what does holding hope look like for clients struggling with suicidality while maintaining realistic awareness of risk and safety?
Hmm. All right. Well, I think holding the tension between hope and realistic risk awareness is like a keystone of our practice. It involves like maintaining empathy, authenticity, and relational connection, sort of like the core tenets that Friedenthal emphasizes is very important for intervention. So I think it looks like validating despair. So like realistic awareness. I start by deeply validating the client's current despair, their the gravity of their pain and risk. This like authenticity, like it builds trust with them. But at the same time, you want to elicit hope, right? So then I use techniques from like solution focused and narrative therapy to elicit like their preferred future and best days. So I treat the desire to die as a statement about a problem, like a desperate attempt to solve unbearable pain, uh, not a statement about the person. So I think that's important. And then managing ambivalence, I use MI. I help the client sort of explore the pros and cons of living and dying, strengthening their reasons for living to overcome ambivalence and obviously the resistance to safety planning because they're like, oh, I don't want to do that. So by creating like a genuine connection, I serve as a catalyst of hope for the client, while systematically and realistically assessing their safety and reducing means. This sort of allows me to address Whiteside's focus on behavior with Friedenthal's focus on connection.
I think that the piece that you talk about, I don't think I've had to use motivational interviewing recently that I could think about, but I mean, That's really neat because, like, it's not about convincing somebody to get better. You're trying to help them connect with the reasons why they want to live differently. And, that's where I just caught that, where, like, you using the motivational interviewing becomes your catalyst of hope. And, um, yeah,
Because they have reasons to live. They're just not always thinking about it. So eliciting that is sort of helpful. Like then they hear themselves talking about it, and it really shifts their attitude. So that's why I use it.
yeah, I mean, you're taking you're giving them meaning and you're letting them know that everybody they have strengths and values that they could build on. And it's you're helping clients that have like spent years feeling judged, punished, and like super powerless. So just being able to have these conversations, they can really be life changing, I'd say.
Yeah,
Just it also invites them to know that, like, the recovery piece, it's not being forced upon them. It's just letting them know that they're capable to, like, author themselves and make sure that they can, get to where they
yeah,
want to be and need to be without being told.
yeah. And I know narrative therapy might not seem like a whole lot at first, but like when I start telling people that they are the author of certain areas of their life, especially like their identity or purpose or desire for life, it usually changes sort of the way they see things and empowers them quite significantly. Where they're like, "Oh, I never really thought of that. I am in control of like how I see myself, who I am, and where I want to be." So when you mix like that narrative therapy with like solution focused or cognitive behavioral therapy or DBT or whatever, like it goes a long way.
Absolutely. And, just to kind of close us out here, if I've learned anything from all of this, it's that we work in totally different populations, but we
Yeah.
come back to, like, the same foundation. It's connection, safety, and basically meaning. And, and I've learned that through child welfare, I use trauma informed care, and I'm sure you use trauma informed care as well, but, like, uh, ecological systems theory, so I could understand how instability and loss shape how my kids express their pain. And you working in the substance use treatment, your lens, you're focusing on recovery oriented. What is it? Recovery oriented, and um, there's another word that I'm trying to think of. It was
We just we just
diet.
call it
Go ahead.
we just call it medication assisted treatment as far as what we do.
Yeah, and you're trying to help your clients rebuild hope and self-worth. And,
Yeah,
across both of these settings, the clinical praxis framework, this just fits because, we're blending the theory, the reflection, and, practice wisdom to guide how we show up, in these high-risk situations. And all these readings that we've been doing, it just reminds us that suicidality isn't just about managing the risk. It's like helping all of our clients restore their dignity and their belonging. And it's in my work, it's the children who can't yet find those words, and it's
yeah,
your adults who are fighting to stay sober. And our work is about meeting people exactly where they are. And I never really understood what this meant about, like, holding space for people, but yeah, it's holding space for both their pain and their capacity to heal.
yeah. That's great.
Well, thank you for being able to collaborate on this assignment with me. I learned a lot about
My
your field.
my pleasure. Me too. And I realize how much harder you have it than I do because I have a 7-year-old, and I can't imagine trying to get her to communicate some of these things in a way that I could understand. So kudos to you.
Yes, and kudos to you as well. The other side is it's not much greener.